there was a panel discussion that focused on optimizing therapy in breast cancer, which really focused predominantly on developing escalation and de-escalation trials in breast cancer. And, I think there's been a lot of work being done to try to minimize toxicity and improve efficacy for patients. And, there are some challenges with trying to develop these trials. Some of the focus was on developing appropriate endpoints for such studies. So particularly when you're looking at a patient population that may have a low event rate with therapy, what is an appropriate clinical trial endpoint in that setting? I think another challenge with the trials is trying to figure out how to think about de-escalation. We want to make sure we are maintaining efficacy, but trying to minimize toxicity. And I think sometimes that's a challenge because you also are trying to factor in toxicity with efficacy. And so one question arises is, should some of these trials think about co-primary endpoints? Should we be weighing each of these items against one another when trying to assess how appropriate a de-escalation study is? And then I think some of it is just feasibility of doing some of these trials. I think one example was when we think about stage 1 HER2 positive cancer, when you treat these patients with effective HER2-directed therapy, the rates of recurrence are exceedingly low. And so how does now one go about developing future trials that could lead to registration? Because if you're comparing two highly effective therapies, it's really almost impossible to feasibly develop a trial where you're comparing efficacy of two arms. And so, it would take, thousands of patients to do such a study. And so I think it would be very challenging. And so we really were trying to think about optimization of these types of trials.